The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you with FlightBridgeED. Today I'm really excited to have a special guest. Many of you guys know Michael Lauria. He's a flight paramedic, past special operations medic, and currently med student. And so we're really happy to have him on the podcast. Been trying to hook up with him for quite a while and have fostered a friendship over the last few months. So welcome.
Oh, thank you very much, Eric. It's a pleasure to be here. I started out actually as an EMT when I was an undergrad, and then sort of progressed from there and sort of got hooked. Then I sort of went into the military, and I decided to become a pararescueman, PJ in the Air Force, and did combat search and rescue, as well as getting to work with some really amazing special operations organizations deployed with both the Joint Special Operations Task Force and the 10th Special Forces Group in the Army, which was a blast. And then decided it was time to get out. I wanted to do some more medicine, in particular the critical care stuff. So I started working for the DART program at Dartmouth-Hitchcock in New Hampshire, and then, man, I was just addicted. So I was just kind of got sucked in and absolutely loved it, and decided it was time to take the next step. So I applied to medical school.
Well, that's really cool. I'm actually jealous and envious. If I was a little bit younger, I definitely would be looking at that avenue. But so, I applaud you for taking that step. That's a lot of time and dedication. And
thank you.
Look forward to seeing you as an MD someday, and being able to collaborate with you on other projects and other things.
Oh, you bet. Someday.
Someday. Well, you're almost halfway through, right? So
getting there, yep.
Yeah, you're getting close. Well, for those of you out there, we often obviously do most of our podcasts related to an educational topic, and that we will do the case studies, we'll do the Nightmare series, we do everything related to critical care, and every once in a while I think it's just it's important that we hit on other things. And I think one of the biggest things that we can do, and obviously the whole foundational component of FlightBridgeED, as you guys know, is how we deliver education and how we invest in others. And this is a huge passion of mine, so it's really neat to be able to find somebody that has a dominant passion like Mike. And I came across, based on him sending me a couple links, he did a lecture at the past Critical Care Transport Medical Conference in April, and he put out a video on YouTube, and I got to say, I watched that this morning, and I was absolutely blown away by just the level of content, the thought that went into it, the pathophysiology and the research that went into it, and it's called Approaching Aristotle. So I'm going to let Mike kind of introduce this concept, and we're going to kind of touch on these different core concepts related to kind of his vision and his passion for the delivery of education.
Yeah, well, thank you very much for that compliment, Eric. My crusade this year and for the next couple of years is to really change the way we do education in EMS and critical care transport in particular. It kind of dawned on me, actually, over several years, the way we taught things and learned things in the military, sort of into the critical care flight world, and then even into medical school. And just sort of dawned on me one day, we really push evidence-based medicine. But what I realized was there were tomes of literature out there, all this data on how we can help people learn things, the cognitive science behind effective education. And the funny thing was, the medical world, both at the medical school level and in EMS, largely is unaware of a lot of those concepts, of a lot of the stuff that's been published. And the way we sort of teach on various levels is just the stuff that's been held down, or handed down from generation to generation to generation. Whether we're teaching, just trying to get people to learn facts and information, whether we're trying to teach people how to do really critical, important skills, or even when we're teaching people how to try and make clinical decisions, a lot of this stuff in medicine is really lagging behind the data that's available out there. So I'm really trying to push the idea of evidence-based education.
Well, and I think that, you really have something here. When I was watching the video, there's a few things in the very beginning of your presentation that stood out. And the first one is just what you talked about. Evidence-based medicine is the foundation of really everything that we are focusing on right now, especially critical care, HEMS. That's the big FOAM-Ed movement. But your statement of, but we don't follow that up with evidence-based education. And that's just like, that just kind of hit me in the face. It was like, you're absolutely correct. I think there's a few of us that attempt to do that. But really, I can say myself, not understanding the underlying pathophysiology, all the cognitive aspects of evidence-based education is something I need to work on. It's something I need to discover. I wrote down the different books that you had listed in the lecture, and I plan on reading those. The other thing that really stood out to me is your analogy where you were talking about you were so excited to go to medical school and to learn the pathophysiology, and you said that just the respiratory side, and you were just so excited to get there, and you sat down, and the professor started writing on the board and had his back turned, and it was basically a big block. And you said half the class got up and left, and it was a huge letdown. And that's profound. And I think that could be done in a completely different way. So why don't you talk about that experience and kind of what led you to write this and kind of dive into this more?
Yeah, so that was definitely the moment where it all kind of crystallized for me. So we start out the first year of medical school going over cardiovascular and respiratory physiology, which, obviously for those of us who do transport, who do critical care transport, that's like our bread and butter, right? That's like the cool stuff that we absolutely love. We do on a day-to-day basis. So going in thinking that, especially this respiratory physiology class, that they were going to unlock the mysteries of the respiratory system for me and answer all these questions I had, I was so stoked. I was really interested. Like the medical nerd in me was just, freaking out. And it was so crushing to get in there and have this guy just put up slide after slide caked with text and sort of talking over people's heads and talking really fast. And I have no doubt that this individual is a brilliant scientist, great physician, and maybe his patients absolutely love him. But as far as handing down or sharing that information, it was terrible, and you could tell that when people were getting up and leaving, and you could tell when people were so frustrated in the days and weeks coming, just grasping some of the basic concepts from that lecture was really, really hard. And I thought back to all of those paramedic refreshers, all of those other classes, all of the conferences I had been to where the teaching or the presentation was pivotal. Like it all revolved. You could have the most interesting, cool concept, and you get someone who, just stands up there behind the podium and reads off the PowerPoint, and it kills it. Or you get someone who can't really translate some very complex phenomenon and make it, put it within your grasp, but you can really sort of take it and digest it and then use it and apply it. It just kills it. But when you have someone who can do that successfully, who can take even the most complex concept, or the driest concept for that matter, and make it interesting and engaging and sort of comes alive for you, it can be a really good experience. And I think a lot of us have had those in one way or another, right?
Absolutely. I think, your other comment of, the presentation, obviously the core content is there. So it's your job as an educator to make that appealing to the person being taught, right? So how do you do that? Was the professor that was presenting the respiratory stuff, was it something, was he just not a teacher? Was it that he was doing it the way they've done it for all these years? Could that same person, if he understood these concepts, could you turn him into a phenomenal, educator on a lecturer level? You know what I mean? So I kind of look at it from that context. Do I think that everybody's a teacher? No, I don't. But I think that each person has, their own gifts, their own way of bringing a topic to life. But I completely agree that you have to be able to bring that topic to a point where it's appealing to that person, and you retain their excitement and why they actually, came to the lecture. Because you're actually correct. When I was at AMTC just a few months ago, there was a couple topics I was extremely excited about. I got in the room, and within 5 minutes, I was just devastated.
Yeah,
absolutely devastated. And that's all I'm going to say about that right now. But I completely agree. So why don't you talk about the logic? The difference. The logic. You've got it broke down into 3 different classifications.
Yeah. So I think that, and this is sort of goes back to where I sort of got the idea for the name, which is Approaching Aristotle. So Aristotle was a brilliant teacher. In fact, he was called the first teacher by many. And if you think back to it and our love and affinity for evidence-based medicine, he was the first guy to really, one of the first individuals that we know of in Western history to propose this idea of empiricism, or in other words, actually going out and testing things around the world, in the world around you, to sort of see if they're true or not, or experiment, come up with evidence of what's actually true, what actually works, and why. And so my idea was essentially going back and saying, so we can look at the logic, the information, the science behind how people learn, and take that and develop our educational material around that. And I think that's really the crux of what the talk is really all about. And that is the essence of what we call brain-friendly teaching, which is changing a lot of what we do so that it falls essentially in line with our natural neurochemical and physiological processes, the stuff how our brain really works.
Yeah, I agree. I think you kind of broke that down, and you have it as unconscious load. How can we store it and utilize it? So that's all based on the delivery, the amount of delivery, right? Total, how difficult the material is. You go into the intrinsic side, how difficult or how easy the material is to retain, and then the amount of load based on the speaker. So the third aspect there, how easy will the material be to understand? Based on the teacher's approach. So how important is that, do you think, in the whole context of brain-friendly teaching? I mean, is that something that is anybody can be taught, or do you think that's an intuitive, aspect of an educator?
So I think that, first of all, I think it's absolutely very, very important. And I'll caveat all of this with the sense that I think there's a spectrum for both teacher and learner, right? On the learner side, even if you use all of the tools in the toolbox and everything that's been uncovered about how to teach effectively to be brain friendly. Not everybody's going to learn it, right? There's still going to be outliers who don't quite get it, and there are going to be people who are incredibly intelligent and pick it up no matter how many you teach it. And on the same in the same way, teachers. Some people are just gifted. They're amazing. Even if they didn't pick up a lot of these lessons, they're still phenomenal speakers and have adapted different teaching modalities over time to really be effective. And there are some that, quite honestly, even if they use a lot of this stuff, may not really get to to be the best teacher in the world. Either way, I think we can really improve by doing this stuff. And I think the key is, just like you said, that extraneous load. So the theory of cognitive load was developed and proposed by Sweller in the late 1980s. And it's essentially saying that you and I, any person at any given time, have this finite bandwidth, right? A finite amount of stuff that we can learn at any point in time. And as you mentioned, there are certain things that we can't change very much, that as educators we have very little control over. Everybody requires some baseline amount of energy in your brain to process things. There are certain concepts that are just going to be naturally harder than others, right? And there is that last piece, what we call the extraneous or extrinsic load, and that is the piece that you can control. So if you if you were to imagine a cross section through an internet cable, right, and you're filling that up with loads or amount of work that you put on the brain. That total amount saturating that bandwidth is determined by those individual loads. And if you can modulate that extraneous load, that last little bit, that piece that's determinant on how you or I present visual images, or how we get people to practice different skills, or how we ourselves are talking or describing things, then you can get people to learn more, retain more, or teach people more complex stuff. And I think that's really one of the cruxes to understanding this.
So let me kind of summarize, just so I understand what you're saying. You're essentially saying that the amount of load that we, put on our students can be heavy, it can be complex, but we have to do it in moderation, and we have to give them time to absorb that, give them breaks, keep those loads limited to a specific amount of time. Is that correct? So they can
exactly
absorb that. So that's a really interesting concept. I about 4 years ago I took, and I don't know if you've taken the National Association of EMS Educators Instructor 1 or Instructor 2 course. But it's taught by a paramedic. His name is Dr. Chris Nolet. He's got his PhD in neuroscience. He's working on his second one. And a lot of the instructor class is based on neuro research, neuroscience, a lot of the stuff that you're discussing. And one of the things that I learned in this class that I use in all of my review classes is we give every student a whiteboard. It's about, it's 12 inches. It's probably 12 by 12. Maybe 12 by 14 inches. We give them an eraser and a Sharpie, or erasable Sharpie. And anytime in the lecture, it could be 30 minutes in, 20 minutes in, I'll have them stand up. And I'll give them a question right off the top of my head based on the material that I just taught. Or, later on in the day, it could be material that I taught 3 hours ago. But it's only 2 or 3 questions. It gets them on their feet, it gets their blood circulating, gets them kind of, just stimulated. We ask 2 or 3 questions. They're given 5 seconds to recall that answer, and they all show their answer at the same time. If they don't know the answer, they just put a question mark up, and then we move on through the day. And that has really, really helped with people getting fatigued, falling asleep, getting tired after lunch, things like that. And it seems to have really helped keep people stimulated throughout the day. And that's all based on that kind of that same theory of, making sure that load doesn't, pour over.
Exactly. Exactly. I think those are two brilliant ideas, especially when we talk about teaching in the classroom. In fact, those are two of the big things. It hits on two of the big low-hanging fruits I think we can hit at. So it's really interesting because one of the ways we can help people learn information the most is exactly what you did, having them recall information. So one of the 5 T's that I talk about is testing and recall. So by sort of intermittently getting people to recall information, asking them lots of questions, which sometimes people don't like, it's actually really good. And I always give the analogy of it's sort of like, for those people who who don't experience snow on a regular basis, hiking up a mountain in 18 inches of snow, 24 inches of snow is very difficult. Sure. But you can imagine if several people have gone before you and sort of packed that trail down, that is much, much easier. And that's essentially what's going on in your brain. Every time you're asked to recall a piece of information, your brain is essentially mapping to those pieces of information. It's finding the routes, having to recall that information. In fact, there's some evidence that it's actually strengthening synapses between the nerves that have to recall that information. So every time you're forced to recall that information, that is absolutely very helpful. And in fact, I don't know if there's any evidence for this in particular, but I agree with you 100%. By sort of randomly interjecting those question periods, that I think is more like the stuff that we run into in the field, right? Because although, you kind of know what the call is going to be like, you generally get certain demographics like age and sex and what the chief complaint or major issue is, right? But how often are we there at the bedside in some outside ED or on the side of a highway and you have to recall information very quickly, sort of on the fly? The other thing that I think that's really great about that is one of the other T's I talk about, which is time. Mm-hmm. So often we do CEUs in terms of hours. We do lectures in terms of hours because it fits nicely onto a clock, right? 60 minutes. It's a nice even number that we generally work with in society. But it has no neurophysiological correlation whatsoever. In fact, every study since the late 70s essentially says that after about, depending upon who you read, 15, 18, up to maybe 20 to 30 minutes, somewhere in there is where most people actually start to experience something called cognitive backlog and start to lose attention. I mean, how many of us have been sitting in a refresher class and after, like 10 or 20 or 30 minutes, you're like, oh man, I wonder what I got to buy at the grocery store, or I totally forgot to do this before I left the house this morning. And those thoughts start to come in because that's a natural sort of phenomenon to get distracted. And I would argue that people in the fire service and EMS have a baseline level of ADHD anyway. We're doers. So I think it applies more to us. So the other reason I think that's a brilliant strategy is because it puts a break in that lecture receiving processing information, gets people to change their body position and stand up and switch tracks in their mind from absorbing information and processing it to having to retrieve information. So those are awesome ideas.
Yeah, I remember when I learned it, I just thought, man, that is just such a simple idea. And then, throughout those courses, they actually utilize that concept. So they're constantly, they give you a whiteboard, they're constantly having you do that exact same thing. So you're practicing it and you see the effect that it has on you, as a student. And so very, very profound. While we're talking about this, I know you've touched on 2 of the 5 T's of knowledge. You've talked about time, and I think time is really interesting. And that's another thing that I learned is that and you still see it. You see it with these textbooks, the AAOS, these large publisher textbooks in EMS, critical care, and these slides, these PowerPoint presentations would be 170 slides long.
Yeah.
I mean, it is like, my goodness gracious. So, one of the things I've learned that I try to do every time I write a lecture is try to limit those slides to, max 50, but, try to keep it to 3 or 4 objectives, try to keep it very, focused on what you're talking about, and limit the amount of information that's on the slide. And that's one of the things I can always see and I was guilty of it. I mean, I'm not saying that I wasn't, but, I look back 10 years ago at presentations that I wrote, there was a lot of information on the slides. And I think that was based on, and I look at this from the perspective of, does the speaker know the content? Right? Mm-hmm. You can always tell if somebody knows the content by the amount of content on the slide. If there's just 1 or 2 trigger points, I know that instructor knows the content. If that thing is filled with stuff, that instructor doesn't know the content, and he's relying on the slide to teach. And that's where you get into the whole, reading off the presentation. So I think, putting very direct objectives on the actual slide to trigger the instructor's memory, and then any notes that you may need, put it in the notes section. Limit the slides to 40, 50, and keep those objectives no more than 4. You should be good as far as time goes, and hit on that time aspect that you talk about in the 5 T's. Can you talk about the next one, which is tell a story?
Yeah, so telling a story, really interesting. And this is a technique used by business executives when they're selling things. It's used by people who get on and give national presentations or international presentations like TED Talks. And really, if you think about it, it's something that's been done since the beginning of time, and we do it all the time too. Right? You come back from a flight and you're talking to people in the hangar, or you're talking to people in the firehouse, and you're telling essentially war stories, right? You're telling people what happened. But the interesting thing is, it's a very effective way to communicate ideas. And the reason is, as your brain is processing information, it has to put together sort of in your mind's eye something that psychologists call a schema. It's essentially like a picture, right, of what something looks like, or the concept of what something, of a physiological mechanism or something looks like in your head, how you think about it. Now, when you tell a story and you fill it with all sorts of sensory information, like what it smelled like, what it looked like, what it sounded like, how you felt, your emotional response, that actually may help that schema get formed a little bit easier in your mind, and may help cement it, building a much more high fidelity picture in your brain, and allow you to recall that information a little bit better. And if you think about it, that's part of our stories too. Like when we shared, I was there, the patient was on the backboard, and then they vomited so hard it went up to the ceiling and was dripping down off the ambulance, all this graphic detail, right? And it makes you cringe. But that's the picture you remember. You remember those crazy sort of gross stories. And they don't necessarily have to be gross, but I think that's really important too. So how do we do that? Well, I think that's basically that revolves around using more cases and patient presentations and personal stories within certain limits when we're presenting, which I think is really, really important. So by telling a story or painting a very vivid picture of a patient and sort of what happened, and using that to explain or incorporate certain physiological data or information that you want to share with somebody about different drug dosages, or how to use the ventilator or whatever, that might be more effective than just telling people pieces of information.
Well, I fully agree there. I think, just the evolution of, for instance, the FlightBridgeED review course when we first started, and we started seeing the reviews, and the reviews were good, but we would have a few case scenarios implemented into the different lectures, and people wanted more of that. And I think, now we have half of the whole content is focused on case scenarios that build on the actual concept that we're trying to teach. And I can't agree more that, sharing a story, we don't want to be that person that is just a storyteller, just to tell war stories for the glory. But I think that, and I always say this, I say this to my daughters, specifically my youngest daughter, she just turned 21. And I say that true wisdom is somebody that looks at somebody else's mistake and learns from that mistake. That they're not ones to have to make their own mistakes to learn, right? So we need to learn from not only our own mistakes, but we have to be smart enough and realize that we can learn from a lot of different sensory inputs all around us all the time. I mean, you're always should be looking at a situation, a story, something on the news, and always be relating that to how can I stop that from happening to me, or something along those lines. So I think telling a story in the right way, there's a very profound part of that emotional connection. And I think that's exactly what you're saying, is that emotional connection. Think about advertising, think about the commercials, think about the marketing strategies that these companies use on television. It's all related to drawing you in emotionally, because you're going to remember that stuff.
Right.
And I think that is a huge thing. And I always say this, and I talk to my wife about this. It's kind of funny. If you talk to, I was talking to my daughter, right? And she was struggling with school, struggling with memorizing different things. And I made a remark. I said, "What did you just watch on TV?" And she spit it out. I said, "So what was the difference? You just watched something on TV, and you're able to retain it like a photographic memory. So why can't you do that with school?" And I think there's a few profound teaching points there. Number one, there was an emotional connection. There was interest. And the presentation drew her in to where she just naturally retained it. So I think all of us have that ability. But it's just like you said, how can we harness and trick the mind to retain as much as possible? So, those are kind of just interesting things that I kind of got off track there. But, I think it relates to telling a story and that emotional connection.
Yeah, I think it brings up another really good point too, which I really don't talk too much about in this particular presentation, but I think you hit the nail on the head. And that is that, we've been brought up in sort of the contemporary up till recently educational theory that you hear in a lot of the different classes, both for instructors and for students, is that, well, there's different types of learners. There are kinesthetic learners, there's auditory learners, right, there's visual learners. And of course, everybody I know in fire, EMS, law enforcement, where we all say, "Oh, we're kinesthetic learners. We like, doing things hands-on." Well, of course we do. A lot of people do. But the important thing is that, number one, now we know that that's kind of bullcrap. Like, we're not into these. You're not sorted into one of these three silos. There's a whole spectrum, and each person is somewhere on that spectrum for how they store information that they hear, see, or do. But those have kind of gone by the wayside. We know that's really not necessarily true these days. And two, that doesn't mean that you can't develop, hone, or change the way that you learn so that you can find ways yourself to absorb information that's either written down for you or presented to you visually better.
Yeah, no, I agree. I agree wholeheartedly. I think, it's kind of a funny thing that you said that, as far as the, auditory versus visual versus kinesthetic, because taking that first instructor course through NIMSA, the very first part of the day, like many instructor courses, they have you take that exam. They have you take a questionnaire that identifies you as a, what type of learner are you. And I've always been able to learn very easily, and I learn, in all ways. Obviously, I think anytime you do something, you're always going to be probably quicker at learning something. But when I took the survey, I was a primary auditory learner. right? And so they separated everybody in the class. There was 30 people in the class, and out of the entire class, there was 2 people out of the entire class that were auditory learners. The majority were kinesthetic, and a few were visual. And so I had just started the FlightBridgeED podcast. I was 2 podcasts in, right? And I'm sitting there at my desk thinking, holy cow, what have I done? I mean, if nobody's an auditory learner, my whole platform is auditory, So I started second guessing this whole concept. And I just finally just trusted and just went with it, and it's turned out to be very successful. But it's funny that you say that was just kind of a funny story related to that made me really second guess even continuing with this podcast.
Yeah, and I think a lot of it's based upon the thing. It's like, what do you prefer? And that doesn't necessarily mean what you can possibly do. And number 2, and a lot of times you get asked those tests, and when you think of those questions or read them, you think about these different scenarios in your head of when you've been presented with different auditory information, or you think about the questions and you see those questions through the lens of your previous experience. And I think that taints a lot of people's responses in a sense, not in necessarily a bad way, like they're bad people or they're wrong or they're stupid, but it just that's the natural tendency that we have, and I think we definitely need to sort of overturn that idea.
Yeah, well said. What do you think about the 2 other T's that you haven't really touched on, technical elements, and then, we kind of touched on that when I was discussing, writing lectures and things like that. But the thing I'm really interested in is tying ideas together. I think that's really, really important. And I think if you can tie ideas together, and I often say that when I teach the review classes, we teach in a way called chunking. And what I mean by that is that I start off the entire course with cellular metabolism, one of my most favorite subjects. And we go from the, ATP production, into the electron transport chain. And then we go into, the critical care oxygenation formulas of consumption and demand. And, we move into acid-base balance. And we try to build on everything. And then throughout the entire 2 days, I refer back to certain things and I try to tie things together. What are your kind of thoughts on that, on how important that is to the learning process?
So I think it's absolutely very important in a number of ways. So the way I kind of think about this in my head is I think about it like almost like a spider web, right? If you just had like a couple of intersecting web strands, it's like that's not very strong spider web. But once everything gets interconnected in this crazy sort of spider web fashion, it's incredibly a strong structure if you look at it from an engineering point of view, right? And I think it's kind of the same with the way that we incorporate our knowledge for a couple reasons. One, practically, we don't have siloed pieces of knowledge, right? You don't, RSI incorporates many different disciplines, from understanding oxygenation, ventilation, hemodynamics, all these other areas. So it's practically how things work, but there are other aspects to it, some cognitive science aspects that I think are interesting. So if you tie different ideas together, if you connect it to stuff that you've taught someone a couple weeks ago or a couple months ago, or tie it into things that you just learned in the last 20-minute or hour of lecture, that can be a very powerful thing because it reinforces those schema in your brain and it ties those ideas to other ideas conceptually. The other thing that's really interesting too is that when you have those aha kind of moments, and I know we've all had them, we've all been sitting there at some point or another and you're like, oh man, I've been doing this for years, and all of a sudden someone tells you something a particular way and the idea is like crystal clear. And it all comes together for you. And you're like, oh, man, it all makes sense now. When that happens, most of us feel good, right? You're like, oh, you get like a little smile on your face. You're like, oh, now it makes sense. Okay. Well, it's very interesting. Because when you get that feeling, that good feeling, that actually taps into the same part of the limbic system, the same dopamine reward circuit that is present in a lot of other areas of our life, right? When you like get your favorite beer or like your favorite dessert, and you're like, oh my gosh, this is so good. That reward circuitry is actually very, very powerful from a memory standpoint. In fact, when you get that sort of dopamine surge in certain areas of your brain, it's almost like the neurochemical save button. Your brain wants to remember that stuff, right? That is actually a survival evolutionary advantage to remember that stuff, that information. So by tying these ideas together, not only strengthens these schemas in your head, but it makes you feel good. It is quite literally like brain candy. So it can be very effective.
Well, and interesting that you say that, because essentially you just tied that back into the emotional side.
Yeah.
Essentially, that is exactly telling the story. We were talking about emotion, tying those ideas together in that aha moment. You have an emotional response to, realizing and being excited that you understand a concept. That's an emotional response. And so again, that's going to, play into how you retain that information. So that's really interesting that those two kind of tie together in that way.
Yeah, and then you can tie it in too, like you were doing with the whiteboard. You're teaching something on a particular subject, and then you ask questions that are associated with it. Like you're talking about RSI checklists, or you're talking about instrumenting an airway or something like that, and you just talked about pharmacology 2 hours ago. You have them stop and say, okay, well, you have all your equipment ready, and we've been talking about endotracheal tubes and bougies and video laryngoscopy, but you need a little bit more than that. So let's stand up and, hey, what's the induction dose for ketamine? What's the induction dose for etomidate? How much rock are you going to give this 80-kilogram patient? Let's say this 80-kilogram patient is hypotensive and they're not doing very well, and you believe that they've lost quite a bit of blood and they're in hemorrhagic shock at this point. How are you going to change your dosages? All that stuff ties into the testing and recall piece. So these are all, again, sort of interconnected.
Yeah, very well said. Well, let's move forward. Is there anything you want to touch on as far as the cognition aspect? I know you talk a little bit about the whole, simulation, how we conduct training as far as the kinesthetic side. And I know we've talked, we talked a few days ago about your experience in Australia, which again I found very profound as far as the ideas that you shared with me. And I'll be honest, I've already shared those with, Alan Wolf, and he was very excited about, the possibility of maybe moving to some type of a element, with regards to what we discussed. But how important do you think simulation is, and do you think that there's any blocks to making a simulation style atmosphere productive? I mean, we talked about utilizing just modest equipment, not utilizing the $100,000 Medi mannequin, and equipment and the flat screens and all that stuff, but using just simple tools to get the same kind of response. Because I think that there's a big disparity. When I used to do simulation with a Medi, you get a crew that's very on top of things, and you're the only one running the scenario. It's really hard to keep up with that MacBook as far as keeping that mannequin doing the things that it should be doing, right? Mm-hmm. And so unless you have a lot of training, a lot of us are self-taught when it comes to that stuff, it's really hard to make that environment optimal. So I think some of your ideas regarding simulation and what you experienced are pretty profound. Can you share anything regarding that?
Yeah, absolutely. So I think that, simulation is one of those buzzwords currently, I think, in EMS and medical training in general. There's a lot being published on it. And I think that that's great. That's fantastic. But we might be missing a couple of important things that I think are putting some hurdles in the way for people. First, the idea that more is more when it comes to simulation technology. And that said, I mean, sometimes people, you see that there's all sorts of companies pushing very expensive, $20, $50, $100,000 high fidelity mannequins. Hospitals are building huge simulation centers where they can do all sorts of simulation, and those are great. That's awesome. I'm not putting those directives or those projects or those ideas down. But I think what's important to understand is, like we said, number one, you can do good simulation with very little equipment. And I had been talking to a bunch of people about this before, but the guys down at Sydney Hems really solidified this in my brain. And they use a combination of very low fidelity mannequins and volunteer patients, and only a handful of stimulus information. So they actually use like an iPad that looks like the front of a Philips, and that way they can adjust just some simple parameters, heart rate, blood pressure, all those ideas, to make you respond to what's going on there, which is really the crux of it, right? Mm-hmm. You are seeing and observing information that's going on in the world around you and adapting or changing or making decisions based upon that, right? And that can be done relatively simply. It can be done with a rhythm generator and a very low fidelity mannequin or a patient volunteer. You don't need a $20,000 machine with wires everywhere that blinks and coughs and goes, help me. You don't need that necessarily. And what I think that part of what that leads to is it turns people off because, like, we don't have any high fidelity simulators. The other thing is, I think we've gotten into our minds sometimes, especially for more experienced people. They're like, well, what do I get out of the mannequin? It's plastic. It's not human tissue. I can't, if I cut into it, it's not like putting a chest tube in a human. It's not like starting an IV in a human. And I get it. I do. But you're kind of throwing the baby out with the bathwater if you just completely shut down simulation based upon those simple things, because you can get a lot out of it, mainly that decision-making piece.
Yeah, no, I agree. I think, there's obviously a place for simulation, but I think it's all in how it's conducted. And can you talk a little bit about the many scenarios that you were, we were talking about the other day? Because I think that was probably the most profound thing that I took from our conversation was making something that's so broad into something very, very tiny, to where, again, we go back to the time aspect, the cognitive backlog. Make something, a huge scenario with a whole bunch of stimulus, but break those into smaller scenarios like you were discussing, and kind of explain to the listeners kind of that process and why you feel that was an amazing experience.
Yeah, so there was two aspects to it. One was the sort of learning by perturbation, and the other was these sort of perforated scenarios. So I'm sure as instructors, we've been frustrated from time to time where a scenario is not really going that well, and you're wondering, do I stop it now? Do I just let them keep going and sort of blundering through this? They're getting frustrated. The student's getting frustrated. You're getting frustrated. And it may be a suboptimal learning experience, especially if this is sort of new for somebody, really new information or training. And again, I'll use the Sydney Hems example. They would do these perforated scenarios. So at these key decision points, they would stop the scenario and talk to the student and rewind a little bit and then allow them to make that decision again. So one of the examples was one of the more difficult things to get people to do is they teach their physicians how to do pre-hospital thoracotomy, which the procedure they teach is relatively simple. But much like Crike, it's what we say the most difficult part is deciding to do it. Mm-hmm. So there's a lot of key decisions in the resuscitation of this peri-arrest trauma patient that had to be made. And at the key points, for example, the time when the trauma patient loses peripheral pulses in the field. big time decision point. Do you start closed chest CPR? Do you start other maneuvers? And a lot of pre-hospital teaching has been, you do what you do with any patient who loses the pulses, which is immediately start chest compressions and go into sort of ACLS-esque algorithm. And so what they do is they would stop at that point and discuss the decision with the student, rewind the clock about 15 seconds or so, and allow them to make the decision again to correct that pattern in their brain, to essentially repave a new pathway and build a new pattern in their mind of how they should be reacting when they encounter a bleeding trauma patient on the side of the road that loses pulses. And that was very, very effective, because instead of just having them, I don't want to use the word bungle, because the residents and the paramedics were going through the program were brilliant. But instead of having them struggle with this new procedure and difficult decisions, it alleviates that. And I think it was a much more effective educational modality. The other piece is this idea of perturbation, these sort of building mini scenarios. So if you want someone to handle a particular situation, evaluating a patient inside and trapped inside a vehicle, clinical procedures like RSI or like starting a central line or anything like that. One thing that gets people and can be frustrated is you learn the procedure, but that's almost never how it presents to you in the field. There's always something a little bit different, or the situation has changed. So how do you teach someone to make decisions and adapt to those different ideas? Well, one of the things they did was this idea of learning through perturbation. So you just set up a scenario, say, a trauma patient in the back of an ambulance that your crew, you land, your crew is presented with this patient. And you start out, run the scenario, 5-10 minutes, maybe 15 minutes if you're doing a procedure like RSI, straightforward, which sounds pretty simple. Mm-hmm. They're okay, hemodynamically stable, their vitals are all right, the tube goes smoothly, everything's okay. It allows them to build their confidence, get comfortable with the procedure. Then you have them do it again. Tweak it a little bit. This time, let's say the patient's tachycardic and hypotensive, and go through those same procedures, have them set up their equipment the same way. And of course, the key decision is how you change your drug dosages, how you change your general approach to this patient, maybe by giving them blood or doing other things, fluid resuscitating them, in addition to the same procedure that they first did. So you're repeating that same basic RSI procedure, but now you're changing it up a little bit, changing pieces and making them make different decisions, and working all the way up to a very sick, critically ill, peri-arrest patient that needs to be intubated, resuscitated, and intubated. And you run into all sorts of problems, whether that be, your laryngoscope fails and you have to transition to another piece of equipment. Or your video laryngoscope fails, you have to transition to DL. You're having ventilation problems post-intubation. So there's all sorts of things you can do. But it builds the basic strategy in the person's mind, and it also, almost like the testing and recall, basically forces them to think through these decisions and map to other places in their brain and develop patterns of how they can effectively respond under stress with different changes to the scenario.
Man, I just think that's so amazing. I think some of the most simple concepts are the ones we don't realize. I think many of us look at things and we want to do things the hard way. And that to me, once it's now explained to me, seems so simple. And it's, again, one of those aha moments where I'm like, man, why didn't you think of that, 10 years ago? That it's just such a simple concept. But, just you explaining it to me makes a lot of sense. And I think you really hit something real big when you said that as the scenarios, the way we do it now, many of us around the country, as the scenario progresses, the instructor gets frustrated, the actual providers get frustrated, and by the time the scenario ends, does the instructor remember all the teaching points? Right? Can he or she articulate the teaching points? And will those teaching points be received? And I would say most of the time probably not, because the providers are so frustrated at that point. They don't want to hear anything. They're not hearing what you're saying. They're thinking about everything that they did wrong. They're trying to go through the different steps that they maybe missed, and so they're not hearing anything you say. So the teaching aspect of that is completely gone. So I think, you talk about this under the skill aspect of cognition, of breaking things down into individual steps, and that's exactly what you're doing. You're making every opportunity small little incremental steps based on little scenarios to, evaluate those small areas, stop, reevaluate, teach on a mistake, and then move forward. And then, by the end, their confidence is high. And they're able to critically think. And I think that's a really profound thing of teaching somebody to critically think. I think that's a very, very important concept that, many of us as educators try to figure out. How can you teach somebody that's got 15 years experience as a paramedic or nurse to critically think? You would think that they would already have that ability. Can you reteach somebody with that much experience to critically think? And I think by utilizing the tools that you just laid out, I think it's very possible. I really do. I think it would take some time, and you would have to spend some time with these people, but I think it's very doable, and I'm really excited to try these concepts out.
Yeah, and I think it's the kind of thing too that, again, when you read these papers about simulation and you read a lot of this educational theory, what I think people don't always take into consideration is, let's say, I'm at my base, which is not at the hospital, and we're at a hangar. Right. And we have, a couple mannequin heads, maybe one or two mannequins in our medical equipment. Right. We don't have a full simulation lab. But if we want to practice skills or challenge ourselves to walk through these different scenarios, we can. You can do it for very inexpensive. It's really more about looking at how people learn and how you can change your teaching to how they learn than it is about spending lots of money on equipment or mannequins or sim labs.
Yeah, no, another aspect of that just kind of proves your theory is when I always think about this. I say this to my wife all the time. I think we've got so much technology around us now. Does technology make us? I don't want to say stupid, but really, does technology make us stupid? And I would say it does. I think if you think back. How old are you?
I'm 32.
So I got 10 years on you. So you're my wife's age. So basically, I think back of the days where we didn't have cell phones. I may had a pager. Remember the days with a pager? My wife would love that when she hears this, when she listens, is my beeper. But I could, I had a thing with numbers. I still do. I can remember numbers. Just like it's nothing. But I think I struggle more with that now, because we have technology. We have the cell phones, everything's stored on our phones, and we don't have to physically dial those numbers. Whereas in the past, you were forced to remember those things. You actually did brain training constantly. So right. I really do think that technology has made us less able to retain information, because we're just not forced to. We have all these gadgets, all these things around us that help us do that. And so I think that is very, very important. I think, a lot of times it's too much technology, just like these medis. I think that they're great. I think that they serve a purpose, but I do think at times they can be a hindrance to the whole process. So I think you got to find that perfect balance and figure that out.
Yeah, it's all about how you use it.
Absolutely. The last thing, and I think the most important thing that I feel, is passion. And having passion as a educator, having passion as a clinical provider. And I think that is so important to be infectious and contagious, like you said. So why don't we wrap up kind of your thoughts on that regarding, just the whole passion aspect?
Yeah, so it's interesting that when Aristotle was talking about how you persuade people to do things, how you persuade people to get people to think a certain way, he talked about not just what he called logos or the logic behind it, but he talked about pathos too. And that, I think that rings so true for a lot of us, especially, you've been at this for a little while. You're up and coming, or, like I said, you've been at this for a little while, and you sort of need something to keep that fire going, and I don't think anything does that better than having someone who's really engaged and really passionate about teaching and sharing information in a way that's accessible to people. And it always drives me nuts when you come into a class or something like that, and someone's there because they're getting paid. They walk in at the last minute and they sort of give you this very drab sort of lackluster presentation. And it's clear that person, is there because someone's compensated them, or they're there because, they want to present at a conference, they can get their name, someplace. But they're really not that passionate. And it comes through in the way they talk, the way they present things. It clearly comes through in how often they've practiced something and how polished their presentation is. And from a psychological perspective, it's really, really interesting. If you take two groups of people in a room, people who are depressed and display essentially negative emotions, and across the room you put a whole bunch of people who are very positive, excited, and exude with their body language and the way they talk very positive emotions, very excited people, very passionate people, without actually conversing with one another. The attitudes, the feelings of the people who are essentially clinically depressed comes up just by being around them. So just by being passionate, your presence, being excited and engaged, can change the way people feel. And that's important because that can change the way people learn. If you look at people who were essentially given a presentation or an idea trying to sell a group of people on a multi-million-dollar pitch for a product or whatever, it's very interesting. Time and again, when you look at the psychology of how people decide, how people remember a particular product or a particular presentation, passion, excitement, interest of the presenter actually rates very high up there, way above how educated someone was or the science or the data they're presenting. So really, just by being excited and sharing that passion, that love of pre-hospital emergency care and critical care, it can make things more interesting and it can make them more memorable.
Oh, I can't disagree. I mean, I think that is probably one of the most foundational things. I really try to show my passion, and I think you try to, the old saying of don't just say that you're this way, but I try to show it in my actions. When I'm teaching, I try to show the passion I have, the excitement for certain topics, certain subjects, for teaching. And again, I think, like you said, it brings an emotional attachment to that person. I hope that the FlightBridgeED podcast has become as successful as it has because of my passion for teaching and for just investing in others. And I think that, that's based on the emails I get, that is a huge thing. I think as long as you stay humble and you show humility and you show passion for what you're doing, I think people will want to hear what you have to say. And I think that is a huge, huge part of being a good educator and a good communicator with other people. I think body language is everything.
Yeah, I agree with you. And, it's interesting. So when I was at SMAC in Chicago, there's this interesting pattern that reoccurred when I would talk to a bunch of the other SMAC speakers, both at the pre-hospital SMAC Force Day and throughout the conference. And we were discussing, how we present and ideas and whatnot. There was two reoccurring things. The best teachers and presenters there all had in common two things. One was that it's not necessarily, you don't necessarily have to be a brilliant educator. You can incorporate some of these concepts, and it's just, you got to care. You got to care and put in the effort and want to put something together that's really good, and incorporate these basic principles, which aren't that hard. And the other thing was, it's all about working hard in practice, which, in my opinion at least, is the manifestation of your passion and how much you care, because you're willing to put in the extra time to design a scenario. You're willing to put in the extra time to practice a 20-minute presentation for hours and hours and hours until it's just right. And so I think that's very, very important. And I think that even my role models, the people who I really look up to, have sort of backed up those concepts in their very practice. So,
yeah, well said. Well, I really, really appreciate you coming on the podcast. I think this has been a great topic. I think it's a needed topic, and I think, we have a lot of listeners out there that are educators, that love to teach, that have the passion, and I think hopefully they can take some of these concepts and apply them. I am going to put the YouTube video in the show notes, and I will tweet this out. If anybody has any questions, I'll put Michael's email address in there as well, if you don't mind, so they can reach out to you and go to the source. I'd rather them go to you than to me as far as answering questions on your content. So, again, I'm very, very excited to have you, share your time. I know you're very, very busy. I do want to say thank you, for reading the new ventilator book and for your kind remarks and comments. That really means a lot, and just appreciate your support.
Oh, no problem. It was a pleasure read. I think it's very helpful and sort of a must read for anybody in the industry. And also, I'll add that I think this podcast, I remember when I first heard it, I was really amazed. The consistency of quality and the regularity at which you're putting out great information, I think is fantastic. I think it's what the industry needs. And from me and for many of my colleagues, thank you for putting this together and providing this educational resource for people around the world. So it's awesome.
Well, I appreciate it. It does. It's like I've said many, many times, it's the most rewarding thing I've ever done, clinically or as an educator. And it's, I think if you go into something like this with that servant mindset, and I say that over and over, you don't do it for anything but just to try to invest in others. I think it's an easy decision, and you're able to come up with content and take the time out of your week, which is really maybe hour and a half. It doesn't take a lot of time to put stuff out and do it consistently. So I really appreciate that. It means a lot.
No problem. Thank you, sir.
Well, on behalf of everybody at FlightBridgeED and Michael Lauria, we want to just thank you for joining us as always, and we really, really appreciate the following. Just continue to send me those emails and ideas for podcasts. Thank you again for all the support on the ventilator book. It's been amazing, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.